Hello friends, I am Dr. Harsh Mathur from Om Netralay, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. And today we will be discussing about this interesting case which looked fairly routine, nothing unusual, but then there was a capsulo-cortical adhesion and their zonules were weak. So let's see how I managed this case. The capsule is stained with trypan blue dye underneath an air bubble, and then the chamber is maintained. With the help of this 2.8 mm steel keratome, the main incision is made and a 5.5 mm mark is made over the cornea. Now as I am trying to lift and make a flap, the wrinkling can be seen, and it is quite difficult to continue with the rhexis with the help of this 26 gauge needle. So now I turn to this utrata forceps, and while I am pulling, you can see there is a stretch of the capsule indicating weak zonules, but I managed to get a fairly round rhexis around 5.5 mm in size. Now the usual hydrodissection, lifting the anterior capsular rim and gently putting in BSS and then tapping the nucleus on the other side to free the nucleus. So now when I tried to rotate with the hydrodissection cannula, it did not rotate. Now I am trying to rotate this nucleus with the help of this dialer, but you can see that the bag is being stretched. Now with the help of these two dialers, I again tried to rotate the nucleus, but this nucleus won't rotate. So now instead of repeating the attempt and risking the zonular dialysis, I plan to go in with the phaco probe. This is Catrax 3 phaco machine. The bevel is turned up. This karate chopper goes in, and time to go and do a direct horizontal chop. So holding the nucleus firmly, I get the first crack. Now without rotating the nucleus, I am trying to catch hold of this central core of the heminucleus, and I am able to divide it into two. Tried to lift this quadrant, but it did not come up. So I went to the other side. Still the nucleus is not rotating, and while chopping I lost hold. So now my plan is to remove this one quadrant that I had managed to separate. Now the attachments are removed, and with vacuum I am able to lift it up. So by now I am hoping that the fluid must have gone underneath the capsulo-cortical adhesion nicely, and I am able to rotate this nucleus now. So now I am going to continue with the chopping. Again, I hold this nucleus and now I get another chop. So this capsulo-cortical adhesions was between this left side port and the main incision. So I'm constantly keeping an eye on that area. Now the moment I do this, some nuclear fragment goes beneath the iris. I'm not sure it's planning to go down or it is just stuck there. So I plan to come out. So now I refill the chamber with OVD, and with the help of the dialer, I'll try to see where that nuclei is and what is the condition of the capsule and the zonules. So now I am removing that nuclear piece. So everything seems fine. Capsule is intact. Now these two large quadrants are still attached. So with the help of two dialers, I'll try to separate these. And I get a good separation. And now again I go in with the phaco probe, trying to lift this quadrant up, nudging it with the help of the dialer. And finally I am able to bring it up. So once this quadrant is up, the rest follow easily. The probe is in the central safe zone. The sentinel air bubble still present. I'm trying to work at the plane of the iris. And now in no time, the two big quadrants are gone, emulsified, and this last nuclear piece is emulsified. Now the power is reduced, and I'm trying to flip this epinuclear sheet. And it comes in the probe, and that's it. So we don't see these capsulo-cortical adhesions routinely in our practice, but if something like this comes up, we should be ready with a game plan. I was lucky, this game plan of mine worked, and I was able to do this case nicely. Now going through the side port and being very cautious, looking at the capsular rim while removing these bits of cortex so that I don't pull the anterior capsular rim and cause iatrogenic zonular dialysis. So now the chamber is filled and the wound assisted IOL delivery is done. It's a hydrophilic IOL. The leading haptic goes in the bag and the trailing haptic is dialed in. The lens is nicely centered, but in the area of the corticocapsular adhesion, there is a slight tenting of the anterior capsular rim. Now you can see it. There is a slight peripheral shift of the anterior capsular rim, but then the IOL was nicely centered, so I did not do any more maneuvers. So that's it. The case is done. The patient was very happy and I am relieved. Thanks for watching.